of your busy weekend schedule for very informative and educative session that we're very fortunate to be together today and have a wonderful and a very well experienced surgeon, who is none other than Mr. Vimal K. Vasudeavan. So allow me to say a few words about Mr. Vimal. He is a consultant general surgeon with a special interest in minimally invasive surgery. So for those who do not know what is minimally invasive surgery, it's basically keyhole surgery, or what we call as laparoscopic surgery. So Mr. Vimal is one of the pioneers in Malaysia who has trained a lot of surgeons, including myself, in the subspecialty of laparoscopic surgery. He's a very passionate educator, and I must say there is a difference between teaching and educating. So Mr. Vimal is able to educate everybody to make it a very simple form to understand. So that's why we are here today, to understand the concept between obesity and your gastrointestinal system. With his vast experience, I'm sure we'll have a lot to learn. And I must again ask all of you, please, if you have any questions, type in the chat box there, and myself and Angeline will bring it up the discussion after Mr. Vimal's presentation. Without further ado, I'd like to welcome Mr. Vimal to deliver his talk today. Thank you.
Thank you.
Thank you, Kiru, for the wonderful introduction. Not sure so much merited. Thanks, Angeline, for always sharing us, making us feel happy. This is the second time for me here.
Yes.
I would like to welcome all the participants for making your time on this Saturday. Right. Okay. So can I share my screen? Okay. Are you all able to see my screen?
Yes, Mr. Vimal.
Okay. All right. So again, a very good Saturday evening. My name is Vimal, and I'm a general surgeon. As Mr. Kiru said, we are colleagues at the DIETARY Hospital, Penang. So I will be talking to you on the effects of obesity on the gastrointestinal system. To honor the World Obesity Day, which fell about 2 days ago on the 4th. Okay, before we talk anything about obesity and GI tract, I think we need to talk about a little bit about obesity and what is obesity and what is being overweight. So WHO defines obesity as a medical condition in which excess body fat has accumulated to the extent that it may have a negative effect on health. So the catchword here is, this is a medical disease, okay, where there's a lot of fat accumulating all over your body, organs and structures, and it has a negative effect on health. Okay, so to many of you who felt that obesity is not a disease, WHO definition says it all. Now, the most common method of assessing obesity or being overweight or your weight in general is using the body mass index, or in short, BMI. How do we calculate the BMI? We take your body weight in kilogram and divide it by your height in meter square. Okay, so there is a range. Normal is below 25, overweight is 25 to 29, and obese is above 30. So, is this the most accurate parameter we have to assess weight? Definitely not, but this is the most universally used parameter, okay, for ease of use. There are many others, chief among which are the waist-hip ratio. You take your waist diameter and then divide it by your hip diameter. Normally, it should be below 1. If it is more than 1, you're already obese. Okay. And then for more accurate assessment, you see the body mass index. the mass of the body is dependent on roughly two main structures, your fat and your fat-free mass. Okay, so the BMI doesn't differentiate. That's why it's not so accurate. Whereas the waist-hip ratio is more accurate. If you want to be more accurate, you got to do body composition, where you can analyze all the various content of the body separately. So how do you grade obesity? Like I said just now, previously we used to have many different classifications. Nowadays, what is followed is on the table 1 there, where we think that we look at people being overweight if their BMI is more than 25 up to about just below 30. Okay, the rest are classed into class 1, 2, and 3 obesity depending on the BMI. Now, if you look at that and compare it to the table below that, that table actually is more for Caucasians or the Western population. Okay. Now, why Asians have maybe people can put their on mute. We got a lot of disturbance. Okay, so Asians generally exhibit signs and symptoms of obesity at lower BMI. That's why the table on the right, my right hand side, shows BMIs lower as compared to Westerners. So, how prevalent is obesity and overweight in Southeast Asia? We are number 1. Okay. Maybe you can ask people to mute their sound.
Yeah, I'll get that. I think participants, can you please mute your chat or mute your audio, please? As is.
Okay. So this is data as of 2011. So overweight population, we are quite high. If you look at obese, also we are the highest in Southeast Asia. At the moment, I think it's above 50%. So half our population is either obese or overweight. Now, what does all this obesity do to the individual or the country? Now, those who are have this obesity have increased risk of many diseases. I will go through them later. And because of all these diseases, they all carry significant complication, and that will burden the healthcare. Okay, for those who are going to the government sector, it will burden the government hospitals, and indirectly the country. Those who go to private hospitals, it will burden themselves if they are paying, or it will burden the insurance if they have insurance. Doesn't mean we have taken insurance, it is free. You yourself are paying your premium. If the insurance payout is high, the insurance will keep on increasing the premium, which comes out of your own pocket. So increased healthcare cost. It is not known, many observation and studies done, that people who are obese tend to take more MCs. Okay, because of that, they lose a lot of working days. So there is a lot of working day lost. So as a person who is obese, you lose a lot of working days. You are either going to the hospital or admitted to the hospital for various treatments. Okay, and what does it do? If I'm an employer, I will look at this too. Most employers do. I'm not an employer, so most employers will look at this. If they see, obese people have a lesser chance of getting employed compared to non-obese colleagues. Okay, this is a known fact. So if you are obese, you have less chance of being employed. Okay. If you are employed, you lose a lot of days due to MC. Now, when you factor in all these medical diseases and all affecting, lifespan of the person is also seriously reduced, which means if you compare an apple and apple, an obese patient, a person and a non-obese person with the same health level, the person who is non-obese will live at an average 10 years or more longer than a person who is obese. Okay, so seriously reduces the life expectancy. So these are the very serious effects of obesity. Okay, see, look at the healthcare spending as a country. Most countries spend a lot on health, obesity-related illnesses. Malaysia is top in the Southeast Asian region. Okay, so now I will zero into the medical complications of obesity, just a touch before I go into the GI specifically. So we know obesity affects every system in our body. Okay, every system in our body is loaded with fatty tissue, adipocytes, and all these have harmful effects on the tissue, organ tissue. Okay, it can be any kind of complication. Right. The more common ones are sleep apnea. Okay, I think this most of you know, obstructive sleep apnea, where snoring is one of the features. This non-alcoholic fatty liver disease, NAFLD, is the most common liver disease in the world right now. It's projected up to about 50% of people in the world have this problem. You see, if you look at the ultrasound reports, most of us will see this report, fatty liver. Okay, and most of the patient, the fatty liver is not due to alcohol anymore. Then we have gallbladder disease like gallstones. Okay, so and gynae abnormalities. I think Dr. Somas will listen. He'll be talking about this in the next few weeks. Orthopedic, Dr. Mohana will be talking about the joint implications of obesity, the osteoarthritis of the knee, the hip, and all that. Okay, if you look on the right side, hypertension, stroke, cataracts, diabetes, increased cholesterol, hypertension. Okay, and more than 20 to 30 types of cancers are related to obesity. Okay, and phlebitis. So these are the diseases and complications. This is where the cost of healthcare goes to. Okay, that's why Malaysia is far forward in the amount of money spent on healthcare for the obese patients. Now, before we go into the GI tract, you need to know this concept, body fat. There are two types of body fat. One which you see outside, which is called subcutaneous fat. It is self-explanatory. It is under your skin. Okay. Then you have the visceral fat. Visceral fat is not what you see outside. It is what you see inside the abdomen. Okay. Now, if you compare the risk of developing all those diseases I showed you just now, if the person has neither of both, they have the lowest risk. Okay. This is where your waist and hip ratio comes. Okay. When the both are more, the waist become bigger than the hip. So the ratio becomes more, isn't it? So what if they only have excess subcutaneous fat and not so high visceral fat? Then they have moderate risk of developing all those illnesses I spoke to you about. But if they have increased visceral fat, okay, and not so much subcutaneous fat, these people carry the highest risk. So we know that it's the visceral fat which increases the waist-hip ratio. Okay, it's not the subcutaneous fat alone, it's the visceral fat. Okay, so when this increases, it protrudes the abdomen and increases the size diameter of the waist. Okay, the hip is more fixed. So these people carry the highest risk of all the diseases I showed you this. Okay, so in short, visceral fat is more harmful. I will tell you why later as I go on. This fat coats the internal organs, your bowel, your large bowel, your small bowel, your stomach, your liver, your gallbladder, your pancreas, your kidneys, okay, the ovarian, the pelvic organs, okay, it coats everything. The omentum, retroperitoneal fat, preperitoneal fat, all this coated. So this is the culprit, main culprit, okay. So what are the peptides secreted by fat cells, adipocytes? So when I mention here, adipocytes, all fat cells, but let me be very clear, it is the visceral fat which produces a lot of these peptides. Okay, nowadays, this concept of these peptides, you don't have to remember if you don't have to, you don't want to, but these two are very important, leptin and adiponectin. Okay, they are blamed for a lot of weight loss, weight gain. Okay, a lot of cancers. These two culprits are blamed for. Okay, a lot of benign diseases as well, which I come to later. So remember these four. There are plenty others, but I give you only these four, which are most important. And there are plenty more which we don't know, which time will tell. Okay, now when we look at obesity and the gut, we know plenty of these hormones for a long time. These hormones affect satiety, the feeling of a craving for food, the feeling of hunger, okay, and then increase the sugar level and all those things, okay. So in effect, they cause you to put on weight. So these are the gut hormones. So one is the peptides released by the fat cells, another one is the hormones released by the gut, okay, which in effect regulate your body weight. Now we go into my topic today. Now, GI and hepatic morbidity, you have to consider them together, okay, associated with obesity. Now let's look at the GI tract first. We start with the esophagus. You have both benign diseases, you have malignant diseases, you have pre-malignant conditions, okay, and inflammatory conditions. Okay, all can happen from the esophagus to the anus, from the liver to the gallbladder, pancreas. Okay. Now, the esophagus is well known. All these diseases which are mentioned here, reflux, most of you know, right? We know that when the BMI goes up, the incidence of reflux increases. There are various factors for this, but that discussion is too detailed and it will probably take one whole seminar, all right? Why reflux causes. But suffice to say that when the person becomes obese, the lower esophagus, the junction here between esophagus and stomach, there's a sphincter there that's called lower esophageal sphincter. It loses its potency. So it just opens up and then the stomach contents start going up, be it acid, bile or gas. Okay, so they can reflux into the esophagus, and the esophagus is not designed to keep this much of acid. So you get heartburn. And when it comes to the throat, you get water breath and reflux symptoms, signs. Sorry. Okay, so prolonged acid exposure to the esophagus can result in esophagitis, inflammation. Okay, and then long term can develop Barrett's esophagus. This is also a known factor. Not all develop malignancy, but some do. Okay. Then in the long run, some can develop carcinoma. So all these are increased in people who are obese. It doesn't mean that you are not obese, you won't get it. But if you're obese, you have higher chance of getting. Okay. Now stomach, also you can get gastritis. Okay. If you're obese, you have higher chance of getting gastritis compared to non-obese person. If you rule out H. pylori. I'm saying if you don't have H. pylori, if you're obese, you have higher chance of getting erosive gastritis, which is very common nowadays. If you are, let me drink some water. Okay, so the same effect if prolonged inflammation has a risk of developing gastric cancer in the future. Small intestine, celiac diseases, tropical sprue, these are all diseases of the barak, masale, okay, present with diarrhea and all that. But because our diet is almost like masale diet now, our BMI also is increasing just like masales. So we are also getting all the masale diseases, okay. These are problems with constipation because of the pelvic muscles becoming weak and then they are descending. It's called descending perineum. Okay, so they, especially women, are very prone to it. So they have constipation. If they are obese, this condition become higher. All right, liver. I said just now, you know, non-alcoholic fatty liver disease. So what happens is you get inflammation of the liver. So non-alcoholic steatohepatitis. Hepatitis is what? Inflammation of the liver. Okay, steato means because of inflammation, the bile cannot flow out of the liver. The liver produces bile. So this NASH, prolonged NASH. So it will start with the normal liver. Liver is the source of your energy. You take energy, you eat carbohydrates, food, you need energy, right? You want to exercise, you want to do daily work, you have breakfast. But if you have food, especially high in carbohydrate and fat, and then you don't exercise or do work, or you just have a sedentary lifestyle. So what happens is all that fat stored in the liver, all the carbohydrate stored as energy in the liver gets converted to fat. So along the course of time, the liver progressively become more and more fatty. And then because of the effect of your adipocytes, I told you, they will cause inflammation. Now, whenever there's inflammation, when it starts healing, it will cause fibrosis. Then over a long run, these people can develop cirrhosis. Now, this is one of the more common reasons for liver transplants in the US. Gone are the days of alcoholic liver disease causing cirrhosis and transplant. It is a non-alcoholic fatty liver disease and NASH, which is most likely to end up with liver transplant in the West. Of course, in Malaysia, there's not much of a liver transplant to talk about, but there are, of course, if the liver surgeon hears me, they won't be happy. There is, but not so much. So there's a lot of cirrhosis going around. So don't think only alcoholics will get cirrhosis. Huh? You keep on eating roti canai, nasi lemak, you also can get cirrhosis. Of course, along the way, you will hear this fellow called NASH, you think it's masale, NAFLD, then cirrhosis, okay? And then you also have increased risk of hepatocellular carcinoma, which is cancer of the liver. Okay, it's an independent risk. It can so if you have fatty liver, you can develop hepatocellular CA. Not necessarily you have hepatitis virus only you will get. Okay, so fatty liver also can lead on to hepatocellular carcinoma. Now, gallbladder disease, this is very common, very obese people or obese people, overweight people presenting with gallstones. Okay, and also risk of gallbladder cancer. Colon, these are the diseases. I will also go through it a bit later. Okay, diverticular disease. You see, one of the effect of the adipocyte is to increase methane production. Methane is one of the gases you find in your colon. So this produces increased methane. So it causes a lot of bloating. Okay, so that's why a lot of them will come with bloating and constipation due to various factors. The GI motility also is affected. Okay, a lot of them can get Clostridium difficile infection. This is what you get usually we used to see when people take antibiotics. I think nurses you would have seen, right? They'll take all those antibiotics and then come with Clostridium difficile infection, okay, which can present as a toxic megacolon or pseudomembranous colitis. They can perforate, okay, often sometimes need surgery also. So nowadays we see this Clostridium difficile infection with those who are taking long-term PPI, your Controlog, your Nexium, okay, all those PPI for gastric diseases. If you take it for a long period of time, you get this Clostridium difficile infection. Also have the same complication. You also see this increasingly with those who are obese. Okay, so you see, you share the same thing as a PPI if you're obese. Cancers, colorectal cancers known to happen. Polyps in the colon known to happen more often in those with obesity as compared to those who are not obese. And the types of polyp which happen is often those who precede a malignancy. Okay. So how risky is it? Let's see. Okay, I spoke to you about all those diseases. Now, when you look at obesity only as a risk factor, this OR means odds ratio. Odds ratio means one risk causing another disease. So in this case, obesity is one risk causing GERD. So obesity, odds ratio of obesity causing GERD is 1.94, means that it's more than 1. It's almost 2 times higher in the obese than compared to non-obese. Okay, so if you're obese, your chances of getting GERD is 1.94 times compared to the non-obese patient. This is what it means. Okay, so it's a simple thing. If you are obese, you have 4 times more chance of getting Barrett's esophagus, which is a precursor sometimes to develop adeno-CA of the esophagus. Okay, so imagine why it's so important to manage obesity. You have to prevent all this. Okay, now for the stomach, also gastritis is very common among the obese. Okay, you look at the odds ratio. We don't need to go to too much details. Gastric cancer also, the obese have higher risk compared to non-obese. So if you look at the diarrhea, I told you, celiac disease, tropical screw, diarrhea disease due to the small intestine, those obese have a higher chance of getting. Okay, this may be due to the developed gluten intolerance and all that related to obesity. Because obesity causes inflammation. I will tell you again later. So diverticular disease is where the colon pouches out. Okay, and then they are susceptible to infections and bleeding, perforations, abscess formations, polyps. I told you. See, all those diseases I mentioned, the odds ratio, relative risk is higher than for non-obese people. Okay. Now, how does this mechanism link obesity to GI? I told you, the risk is increased, but how? Okay. So if you look at this table, we don't have to remember all. These are the factors which affects, and this is the mechanism and what diseases they produce. Okay, this one is just for the references I chose to pick it up from. So if you look at it, mechanical. Now we looked at GERD, right? You see, when you're very obese, your abdominal pressure is very high. So the junction between esophagus and stomach gets compressed. Okay, so sometimes because of this, the esophagus cannot move. It causes dysmotility. Then the lower esophageal sphincter becomes weak. The acid can go up. Okay, see? And because of the abdominal pressure, the stomach can be pushed into the chest. That's what called the hiatus hernia. Okay, and for the colon also, same. The increased colon pressure pushes out the colon. And then as you grow older, the weak parts of the colon pouch out like diverticulum, like pouches. So feces sits inside, and then 2 things can happen. One, suddenly one day the feces from the diverticulum drops out and the patient can start bleeding. Or, feces inside the pouch carries a lot of bacteria. The pouch gets infected. It can perforate, form an abscess or peritonitis. Okay, so these are the things can happen. with diverticular disease. Okay, so now that's the mechanical because of pressure. Now, a lot of these fat cells, I showed you the adipocytes producing the peptides. Okay, a lot of them have pro-tumoral function. So that's how they are linked with GI cancers. Okay, the details are very elaborate, even I cannot understand. Okay, so, but suffice to say, when you have increased visceral fat, all the factors are released and they can cause GI cancer, which I have already told you. Now, dietary factors, okay? Your food rich in carbo, unsaturated fat, okay? All this will cause dysfunction. It will change the microbiota, the bacteria in your gut, you know, your stomach got bacteria, small intestine got bacteria, your colon got bacteria, your rectum got bacteria, but there are normal bacteria, okay? But when you take a lot of fat and carbo, okay, this bacteria environment changes from normal bacteria, they become abnormal bacteria. And those abnormal bacteria are the ones which cause, also they are implicated in these diseases. See, these are all functional diseases. Huh? They are not organic. You cannot go and diagnose them. You have to exclude other diseases. Okay, IBS, irritable bowel syndrome. Patient come with pain, abdomen, change in bowel habit, maybe constipation, but usually diarrhea, usually after meals. Okay, so you do your blood test, you do your scope, upper, lower, ultrasound, everything is normal. So you cannot demonstrate any disease. So after you exclude everything, you term it as irritable bowel syndrome. Okay, functional dyspepsia is another. Patient comes with epigastric pain. Epigastric pain, you all know, can be anything, right? But most of the time we think it is gastritis. So you do all the tests, everything is negative. Then we term them as functional dyspepsia. Okay, GERD also similar, but we do have tests to confirm GERD most of the time, not all. So these fat cells also can cause inflammation and can lead to diseases like fatty liver. I told you, no, got inflammation. Pancreatitis, inflammation of the pancreas. Okay, irritable bowel disease. Okay, so these adipocytes control GI motility and a lot of motor disorders, the esophageal movement, stomach movement. That's why a lot of them, after you treat for many months, they don't seem to get better because these are all functional disorders. So we tell them to lose weight. Now let's look at the relationship between, it's a very simple flow I put up to look at relationship between obesity, then occurrence of GI diseases and impact clinical outcome. So when you're obese or overweight, your risk of occurrence of GI disease increases. And when that happens, your treatment response to that disease reduces, and then the outcome is impaired. Now let's throw an example inside here. Okay, let's look at GERD. If you have gastroesophageal reflux disease and you are overweight and obese, the risk of occurrence of this disease increase. Okay, so not only that, because of obesity, the response to treatment is reduced. Okay, and then the outcome of treatment is not sufficient. See, so you can put many of the diseases I described to you into this and get the outcome. Okay, so this is how your fat affects the tissues around. It changes the bacteria content of the GI tract. It impairs the movement of the bowel. If the movement is affected, what will happen is a lot of functional problems, like I mentioned, can come. Okay, now enhanced sensitivity. Okay, when you're obese, this causes irritable bowel. Your stomach distends, normally there's something called gastrocolic reflex. When you eat, you don't need to run to the toilet, right? But people with irritable bowel, when they eat, when the stomach distends, they have to run to the toilet immediately. Okay, I'm sure most of you will have this also. Okay, because you all are mostly nurses, right? So you all makan tak kira masa, so you may have this enhanced sensitivity. This is called enhanced gastrocolic reflex. We see it in animals, dog. If you have a dog, you feed the dog, then immediately you must take him for a walk, otherwise he better in the house, correct? Because they have very enhanced gastrocolic reflex. So when you're obese, that reflex also is increased. And so you makan, you have to run to the toilet. Okay. So this I already explained to you. Obesity, where the bacteria in the gut changes and then leads to increased uptake of complex carbohydrate and all that. So increased energy, and that in fact causes obesity. So obesity causes obesity. You see? So when you're obese, you're more likely to stay obese and become more obese because of this cycle. Okay. And then this diverticular disease, IBS, and non-alcoholic fatty liver disease, IBD, all I explained to you already. Basically, I told you about this methane and all that. Huh? Right. I think I went through this also. Good. How it the contents of stomach refluxes. Okay. So what we know is when you lose weight, it improves symptoms. Weight loss of about 10% improves symptoms of reflux. Okay, but some people very obese, the reflux cannot improve with weight loss 10% also. So we need to consider surgical strategies. Now, irritable bowel, you see, cramping pain in the abdomen. But when you scope, there's nothing wrong. Looks totally normal. Okay, this is very functional. Diverticulosis, you see these pouches I told you because of increased colonic pressure. Okay, lack of fiber in your diet. Obesity is one of the causes of this. Reduced motility and increased gas in the GI tract. So inside the colon, you see lobang-lobang like this. So feces will stick inside and then can cause infection and pecah. Okay, irritable inflammatory bowel disease. Now, this I didn't mention earlier. The most common ones are ulcerative colitis and Crohn's. Now, when I was younger, working in government hospitals, we always thought, when I was a medical student even, we thought that this one is the disease of orang putih. Only the masalah will get. But in the last 10, 12 years I've been in Penang, we are seeing more and more of these diseases. And it's not Masalaya, it's all Asians. Okay, it's all related to obesity because our lifestyle now is more sedentary. We are eating more, and all this fat is causing inflammation of the colon in the case of ulcerative colitis, inflammation of the colon, small bowel, and the rest of GI tract in the case of Crohn's disease. Okay, so this is non-alcoholic fatty liver. You see, liver is a site of storage. And then if you don't use the fat, it will go to non-alcoholic fatty liver, and then inflammation continues over a long period of time, projected between 12 years, 7 to 12 years, 7 years, 12 years, and then a bit more than that. Okay, so non-alcoholic steatohepatitis, and then cirrhosis, and then gone. Okay, pancreatitis. This is your pancreas here. It can get swollen. One is due to how obesity can cause gallstones. Gallstones, one of the leading causes of pancreatitis. Fat cells around the pancreas itself, they cause inflammation and can be an independent factor to cause pancreatitis. Now, GI cancers, you don't need to look at details of this. Just suffice to say these are the many cancers associated with obesity. Okay, though you see them in non-obese, but if you're obese, your chances are getting higher. I think I showed you that earlier, right? So in conclusion, there is increased body of evidence supporting the relationship between excess adiposity, means more fat, to risk of developing GI diseases. Okay, I think we have gone through, I've shown you the diseases which are caused, how they are caused, what factors affect them. Okay, and when you're obese and you develop these diseases, the disease is more severe. When you're obese, you have diabetes, you got heart problems, hypertension. So the diabetes kicks another cascade of events which can worsen or cause worsening of the severity of the diseases you get. Okay, and then when you get the diseases, not only is very severe, the response to treatment will be lower. You see, so when response to treatment is lower, you are looking at higher chances of complications and increased unfavorable outcomes. Okay, morbidity is increased, hospitalization is increased, complications are high, reoperations are high. When you do surgery, the tissue don't heal. Okay, so being obese is a surgeon's nightmare, you know, when we operate. Not for obesity surgery lah. I'm talking about other surgeries, and we see a patient who fills up the entire OR table. It's a nightmare. Anesthetists have a nightmare intubating, surgeon has a nightmare operating and then managing post-op, because there's one bookload of complications which can happen, and if you're not careful, it will happen. And when it happens, you have to manage them. So all this increases the economic burden on the person, on the patient and his family, on the hospital, on the country. Okay, so in short, we need urgent therapeutic strategies to combat obesity. That's why because it is a World Obesity Month, so we are doing what we think we can do to educate people. Okay, now it's difficult for us to stand on top of Gleneagles and shout out to everybody. Nobody will listen. So we give talks like this to people like you, healthcare workers. You go out and talk to your colleagues, send out the message. Okay, we need strategies. The strategies are all there. Okay, lifestyle, dieting, non-endoscopic procedure, gastric balloon, bariatric surgery, they all help. Preventive program also very important. And you know, all these things I told, they are present in the young age also. Okay, in children, in teenagers, all these diseases, all these risks present in them also. So if you want to do preventive program, you have to go back and do it in children. You have to abolish obesity in childhood. So therapeutic strategies for managing now, preventive program, childhood and adult. Thank you.
Thank you, Mr. Vimal. That's a very informative session. So we're going to open up for Q&A right now. I think we have a first question from one of the participants asking how to know...
Okay, I keep the slides in case
Yeah, you can keep the slides on. So just the first question that came up is how to know we have either SBC or VSC fat in the body.
Okay, very simple. Like I said, BMI doesn't tell, correct? So you can give a tinkle, come to our clinic and do a body composition. Okay, most likely, body composition is very accurate, but it is not widely available. Let me show. Okay, body composition is the most. If you are obese, then you can use BMI. If your BMI is high, then and your waist hip ratio is high, okay, then you need to do a body composition. If these two are low, then probably you don't need to do lah. If your BMI is 20 or 22, 24, don't need lah. But I know my nurses in the clinic, they are doing this. Every day they are doing body composition. So my take is, if your BMI is high, waist hip ratio also is high, more than 1, then you need to do a body composition, no choice. So that's the most accurate way of telling whether you have visceral fat or not.
Thank you, Mr. Vimal.
Kiru, anything you want to add? Okay. Any other questions?
Any other questions from the floor? So, Mr. Vimal, can I ask you one question since there's no questions from the floor? Now,
Yeah.
does obesity increases the risk of cancer? That's.
I think I showed all the cancers which are increased with obesity.
Yep.
Yes, it does, due to the various factors, like I mentioned. So it increases the risk of several diseases, not just cancer, but it is known to affect mostly cancer of the esophagus, stomach, pancreas, gallbladder, colon. Yeah, so definitely does.
So any diet measures for an individual or prevention steps that we're looking at?
Like I said, let me see. Diet measures you want to see. So these are the, okay, I mean, I will just, we need, okay, diet measures, yes. Like I said, what you take is what you get, you know. So if your food is rich in carbo, unsaturated fat, you know, low in complex carbo, you know, all this will cause you to have increased uptake of your sugar. Then that will cause obesity. I think I showed that. Yeah. Okay. So when your complex carbo is degraded, complex carbos are what you get in your fiber and all those things, long chain fat carbos. So uptake is more, can cause obesity. So if you want to break, you need to eat low calorie. Okay, of course it's difficult. People don't know how to calculate, but generally food rich in rice and rice is a lot of carbo. Food rich in the starch, a lot of carbo. So you need to avoid them. So food is one thing. Okay. Second is lifestyle. You got to be very active. Sedentary lifestyle encourages obesity. You see, you take so much of calories, you must also burn it. So intake is caloric intake, what you eat. Caloric output is what you burn. Now the difference is called caloric deficit. If your caloric intake minus your output is very wide, you know, you're not burning enough, all that it will accumulate in your body. It becomes fat. Okay, so you've got to watch how much you eat and how much you burn. So that's why the concept of diet and exercise. One is to watch what you eat. Second is how much you burn. So if you burn more, you can take a bit more. But it's very difficult to maintain your weight based on these two. Okay. But for a normal person, not very high BMI, this is easier.
Okay. So that's a question from Dr. Somers. He's actually asking, how do we lose visceral fat without medication?
Without medication?
Without medication, yes.
Well, like I said, to reduce the caloric deficit by eating habits and increasing exercise. Okay, so that is no medication. Like what Somas does, you know, gets up at 5 o'clock in the morning, goes for a walk every day, 10,000 steps. There's plenty of benefit to that. Okay, Kiru runs up during the MCO 18 floors in his apartment until he was stopped by his the condo punya security. Yes, okay. And I have during the MCO I started walking up Gleneagles 17 floors after lunch every day. Okay, and then the car parks were all empty, so we were walking around the car park. So you need to walk at least 5 to 10 kilometers a day. 5 is okay, and target 10,000 steps a day. So that will increase your output, and then you also have to control your input. See, human beings are not designed to eat 6 meals a day. When we were maybe cavemen, we only our forefathers, they only ate maybe one meal every 1 or 2 weeks. So what the body does, it stores everything because it does. They go through a period of starvation. See, you eat a heavy meal one day around the fire, everybody sits, and then after that, for the next 1-2 weeks, until they go hunting and find another animal, then they get the next meal. So you don't know when that will be, right? So your body stores it. So nowadays, we have come a far way. We get food everywhere. You just reach out, you grab food. You reach out, you grab food. Now, so much so they call it grab food, right? So it's so easy to get food now. So what will happen is, the body doesn't know that you are going to eat every meal. Every time you give it nourishment, it will grab and keep, because it thinks you're not going to eat for the next two weeks. Okay, so for the body to change, it will take another few, maybe 100 years or so. Okay, a few 100 years for the body to realize that all this has happened. Because all this has happened in the last 50 years only, 50 to 70 years. I think when I was younger also, the concept was eat, walk, everywhere. We were all outdoors until the parents had to come running after us, isn't it? So nowadays no more. Kids have become sedentary. All they need is an iPad or your phone. So reduce intake, increase output. That's one way. Second, if your visceral fat is high based on body composition, you don't want medication, then you can control your intake. Gastric balloon, Kiru is doing it. You have via endoscope, non-endoscope. Third, we have visceral fat very high, you have medical problems, comorbidities. Okay, then you will need surgery. So these are other things. Medications are there available. If you don't want medication, then the other strategies are these. Because if your BMI is very high, you can walk until kingdom comes. Very difficult to reverse the deficit. What say you, Kiru?
Yeah, that's what I was. I think one thing I love about listening to your talk, as always, is always that you make it very simple and very easy to understand. Tailing into what you just said, we got a question on Facebook, our Facebook platform. The question is, why is bariatric surgery getting popular now, especially in KL?
Okay, I will take that question. Thank you. It's a very astute observation by whoever asked that question. Yeah, I hope it's not you. Okay, so bariatric surgery is on the up. All right. I started doing bariatric surgery in 2005. At that time, there were 1 or 2 other surgeons in KL doing it. Okay, not many. But now we have many people. Unfortunately, in the northern region, not many. The only there are 3 in Penang who are credentialed to do. 2 are here now. 1 more is in Ireland. Then there are 1 or 2 smattering people in the north. That's about it. Then Ipoh, we have 1 or 2 surgeons doing. So most of them are in the Klang Valley. And so naturally they have progressed. And the places which started doing were in the Klang Valley from the beginning. So we are a bit later catch up in the private sector. Most of my initial work was all in the government sector. So that's one reason. Second, Penang Plus, cheapskate . All one, sorry, all one, cheap and best and free. Okay, they will go to private hospital, they say, I got insurance, I want bariatric surgery, but insurance doesn't cover, at least for now. Things may change in the future. Whereas KL, people are cash rich, they don't care so much, they want to do something for their health, they are willing to pay for it. Not saying Penang people won't, but they rather not spend for it. But KL, the mentality is different. Their earning power is higher, so they will spend also higher. So I believe this is the reason. And then the celebrities all are in KL. So when they do something, there's a lot of use of TikTok and Instagram, which old man like me, I don't know. Okay, I also didn't care. I was just doing quietly for all these years until Kiru joined me, and yeah. So it's still a journey for me. Okay, so these are the reasons, I think, why KL is doing more. But we have equally good system here. Like Kiru said, the most pioneer system in the country. Probably about 25 years of experience between two of us.
Yeah. Yeah. In addition, Mr. Vimal, I also think so that maybe programs like this with the platform that we're doing our webinar and all that, by sharing the education and all that, people will know that it's not available in KL. It's also available in Penang, and I think you just have to reach out to them and make them know that it's available.
Yeah. I remember when my first few cases, some were from Germany and UK and Australia, and then they used to say, why you don't advertise in the social media, online? So there's something called advertisement rules in Malaysia, and they're very strict, so you're not supposed to advertise. Whereas other countries like Singapore and all, you can advertise anywhere, you can put billboards and all that, So that's why, but those rules are slowly changing. That's why nowadays you can go on TikTok and all that to do this.
Okay, Mr. Vimal. There's another question from Dr. Somas. There are many different types of diet in the market, such as keto diet, high protein diet, etc. So what's your opinion on dieting, and do you diet?
No, I don't diet. I was very skinny as a child. So all my life I was skinny. So I only started putting on weight later in adult life. So anyway, there are plenty. It's a $1 billion industry. This dieting fad, keto diet, Atkins diet, they all come and they will go. They will come and they will go. The problem with this kind of fad diets is it looks good when you lose weight, but the measures taken by required is quite extreme, and not many people can tahan these measures. So what will happen is they will do for 1 month, struggle, hey man, I lost weight. Then after that, the second month, they're already struggling, and then no energy, because really severely cut down the intake, isn't it? No energy, they're floating through their work, memory problems, and lack of focus, their work affected, personal life affected. So they cannot tahan. So what they do, man, I cannot really lah, antai. So the weight regain is more than what they started with. So this is results in yo-yo weight. Weight increase, loses, increase, loses. And this is not good. A lot of diseases can come from this yo-yo loss of weight. Okay, chief among whom, which is gallstone. You keep on losing and increasing weight, you get gallstone and many problems. So yes, they are. The ones I have been attracted to is this concept of intermittent fasting. I think it has promise. Personally, I think Mr. Kiru and me are still researching the effects of intermittent fasting, because there is no extreme measures, except if you try to extend more than 16 hours of fasting, is probably not possible or proper for your body. So yeah, I think that's the way. All this keto diet and all this maybe for short term. If your BMI, your weight is maybe more about 2 kilos overweight, you want to lose it before you get into your favorite baju, go for the wedding, look macho and dapper. Yes. But if your BMI 45, forget it. Okay, so much, your BMI coming up to mine already.
Anjali, any questions on Facebook platform, anything?
Nothing on my side. No, nothing on my side. Yeah.
Okay, I will stop sharing.
I'd like to ask you a question regarding surgery for the improvement of gastroesophageal reflux disease, because there are a lot of people who are silently suffering with gastric symptoms, and they think that they just go to the pharmacy and buy medication, and they're over the counter. But in the long-term effect, they don't know actually they're silently suffering from a disease that actually is treatable and curable. What's your opinion, please?
Okay. So when you look at gastroesophageal reflux disease, permit me to start from an overview. You need to look at two categories of patients, those who are not obese and those who are obese. So especially in the last 1 year, especially during the first lockdown, I learned a lot about gastroesophageal reflux because of the psychological impairment it has on people. See, getting a heartburn it can be a life-changing situation, life-altering situation. You don't get a diagnosis of heartburn. You are driving or you are doing something and suddenly you get chest pain. If you are 40-something-year-old man or 30-something-year-old man, when you get chest pain, that's it. No, you feel you have got chest pain and you're going to get a heart attack. You've got a heart attack and you're going to die. And this is worse if you have children. They are dependent on you. I've seen this. And when the lockdown came, all this became worse. I had to admit many patients, put them on anxiety medications. Okay. So treatment is lifestyle. Now, the only lifestyle thing which works, scientifically proven, is weight loss. If you lose about 5%, you see some changes. If you lose 10% of your body weight, you see effective changes in reflux. Okay, so because the various factors are so lifestyle. Now a lot of people come to me and say, I cannot take coffee, I cannot take Milo, I cannot take milk, I cannot take yogurt. One list of it, and then when I look at the list, they look depressed when they look at the list. I look at the list, I also look depressed. So I tell them there's no scientific evidence. You can eat what you want. The most important thing is to eat regular meals. Don't skip your meals. See? So if you've got reflux, you cannot do intermittent fasting kind of things. Go on. Okay. So regulars. Don't skip. Your stomach needs food first thing in the morning. You must give. So those are lifestyle. Then you have pharmacological drugs, medications. We know PPI or some form of prokinetics, okay, to reduce the effects of reflux. It doesn't stop the reflux, but it reduces the effects of the reflux. So these are pharmacological, okay. Antacids. If you chew Gaviscon or Malox, what it does is it neutralizes the acid. So it gives you temporary but effective relief for a while. So more long-term or more definite management will be surgery. Okay, surgery means what happens is the anti-reflux mechanism at the cardiovascular junction is impaired. So we have to repair it or redo it. Sometimes patients have a hernia, you have to repair the hernia. Okay, and then we do fundoplication. Okay, all this is done laparoscopically, keyhole surgery. So patient only stays in the hospital 1 day, maximum 2 days. That too, even the first day they are bored already, just waiting to go home. Okay, these surgeries were all done by open surgery those days. That's why they're popular. But in the last 10-20 years, it's all being done laparoscopically with very good results. Okay, so the problem is patients who have reflux tend to go to 3 people: GP, gastroenterologist, surgeons, right? Those who go to GP, the GP will put them on a medication, but sometimes they will put on medication like proton pump inhibitors, Controlol, Nexium, and all that for months on end. So the most protocols say empirical treatment 2 weeks to 1 month. If it doesn't improve, you need scope or further workup. Then you can treat some more for 6 to 8 weeks. Any treatment beyond 2 to 3 months should be discontinued because PPIs are not as safe as they are sounded out to be. PPIs, see, we know they cause renal impairment, they cause Clostridium difficile thing. So if you use prolonged PPI in the US, If patient sues you, you lose. Okay, so the surgery is a good tool, but of course, not everybody will benefit from surgery. That's why in some patients, we will do pH study and manometry to choose good patients so that you can ensure good outcomes. So these are all the things. But very obese people, I will say BMI more than say 30, 32, 35, the effect of anti-reflux surgery may not be enough. So there needs to be a component of bariatric surgery. So what we do is we will do gastric bypass. So when you do gastric bypass, immediately the reflux gets cured. And because they have done a bypass, they also lose weight. Okay, so the factors causing the reflux is removed. Plus, you give them a healthy lifestyle. They lose weight, their body image improves. If they have diabetes and hypertension and all that, the disease can be controlled. So all these benefits are there to a simple thing like reflux. So for non-obese, all this plus anti-reflux surgery. For obese, all the other methods plus bypass.
So basically, we have medical treatment, and for certain patients also, we have surgical options also, which is available for them. The other thing also, Mr. Vimal, we were talking about upper GI and lower GI. So the diagnostic tools, of course, you went through this one. Can you tell us a little bit more about scopes, doing an endoscopy, OGDS as well as a colonoscopy? A lot of people feel a bit afraid, so maybe that's why they're not coming. They don't know the power of these diagnostic tools, as well as, is it possible? Do you need to be admitted, or can you do it as daycare and so on?
Okay, so these scopes for the GI tract, normally for the upper GI tract, it's called OGDS. Okay, esophago-gastroduodenoscopy. Sorry, OGDS. And for the colon, it's called colonoscopy. Okay, of course, very rarely or in very select places, they do scope for the small bowel, which is called enteroscopy. Nobody, I think in Malaysia, maybe in there was a time where they had enteroscope. So to view the small stomach and the second part of duodenum, you can use OGDS. You can go in. It's a very safe procedure. You just need oral and throat anesthetic and sedation, a mild sedative. You may be mildly awake or just slightly sleeping. Okay, so we like to make the procedure as pleasant as possible. Then we will do the procedure, go through the mouth, esophagus, stomach to the D2, have a look around, see whether any pathology, see whether we need to do any biopsy, check for H. pylori. So the whole thing finishes in, if we're not doing any procedures inside, just checking, it takes less than 10 minutes, very quick. Okay, and you can rest, recover, go home the same day. You may feel something in your throat for a day, and you're back to normal the next day. Most people don't feel anything. So it's a very simple and safe procedure to check the stomach. That's why most of the tests which was done those days, barium swallow, barium meal, follow through, all become almost obsolete to check. Because those tests, you can only see, you can't do anything. OGDS, you can see and do something. Yes. Whereas for the other end, your colon, the same test is called colonoscopy. Self-explanatory. You go through the anus all the way to the cecum and then come back. If you see polyp, you can remove them. Big polyp, you can biopsy. If you see tumor, you can biopsy. You can tattoo. Okay. Nowadays, even small tumors, very early cancers around the rectum, they're excising using the endoscope. Okay. It's called EMR. So technology is available. So this prevents unnecessary surgery. So all are done daycare. 99% of our scopes, at least in clinicals, is done as daycare. The 1% is for sometimes patients get admitted for emergency bleeding, obstruction, or whatnot. Then we will admit and do.
Yeah, I think this ties well also with the current colorectal awareness month as well. So I think those who have altered bowel behavior, recent loss of appetite, loss of weight, or alarming symptoms like bleeding in your GI system, then kindly get yourself checked up, get your history checked up, and also register yourself for a colonoscopy or endoscopy. Angeline, any questions? I think you're muted. Yeah.
Last question from the floor. When would you or Mr. Q recommend bariatric surgery for an obese person? Is it related to BMI or to their comorbid issues?
This one I let Chiru answer.
Okay.
Throat sudah rosak.
Thank you.
Last question from the floor. Yeah.
So bariatric surgery we recommend for obese individuals, like Mr. Vimal rightly pointed out. We have the classification for BMI for obese individuals according to WHO, which is for Caucasians. That means they consider people who are obese class 1 at BMI 30 to 35, 35 to 40, and grade 2 obesity more than BMI 40. But for us Asians, our comorbidity begins at 2.5 BMI lesser. So our obesity begins at 27.5 BMI and above. Okay. But bariatric surgery is interesting is that we, according to guidelines, standard practices, and our consensus guidelines is actually ironically coming out this month as well, like Mr. Vimal will share. And according to BMI, if your BMI is more than 32.5 with medical conditions like diabetes, hypertension, and so on, you are eligible for bariatric surgery. If you do not have any medical conditions, then your BMI above 37.5, you are eligible for bariatric surgery. So this is what we call as BMI centric. Now, for those who have comorbid issues, like I mentioned, diabetes, hypertension, obstructive sleep apnea, the whole list that Ms. Vimal has showed just now, even GI symptoms, then we can combine bariatric surgery together with your GERD surgery, or we can combine bariatric surgery with your hiatal hernia, or even your ventral hernia surgery as well. Again, it has to be case-to-case basis because we have to assess you as an individual and to decide what treatment option to suggest for you. So I think in short, that's the answer.
Okay, thank you very much, Mr. Kirill. I guess there's no other questions. Is there any other questions from the floor? Okay, so if there's no other questions, I guess this is a wrap for the session. Thank you very much, Mr. Vimal. I think it's a very informative session we had tonight. Mr. Kirill, thank you so much for your time. We'll see you all next week for the next session. And dear participants, thank you very much. And thanks for the support. See you all soon. Good night.
Thank you.
Thank you.
Have a nice Saturday. Cheers.
Yes. Cheers. Bye.
Okay.
Bye.
Bye.
Bye.